Hello, welcome back to Health Code Blueprint. Today we're diving into Chapter 18 of the ICD-10-CM series, the chapter that covers symptoms, signs, and abnormal clinical or lab findings, codes R00 through R99. This chapter is really the holding area for uncertainty. It's where we code when the provider hasn't yet identified a clear diagnosis. And because this chapter is used so often in real-world documentation, understanding when to use a symptom code versus a definitive diagnosis code is essential for accurate coding. As always, this presentation is for educational purposes only. It's not legal, compliance, or billing advice. Make sure to follow official guidelines and your organization's policies when making coding decisions. Let's get started. So let's begin with the big picture. Chapter 18 is designed for situations where the provider documents symptoms, signs, or abnormal findings, but hasn't yet confirmed the underlying cause. The key question you always ask is, do we have a definitive diagnosis? If the answer is yes, we leave Chapter 18 and code the diagnosis from the appropriate body system chapter. If the answer is no, meaning the provider hasn't established a cause, then we stay right here in Chapter 18 and code the symptom. It's a simple decision tree, but it's the foundation of this entire chapter. This slide highlights the golden rule of Chapter 18. If the provider has not confirmed a diagnosis, we code the symptom. For example, if the patient presents with dizziness and the provider hasn't determined the cause, we assign the R code. But once the provider does confirm the diagnosis, even if the patient is still being treated for the symptom, we no longer code the symptom. The diagnosis takes priority, and the symptom becomes implied. This rule applies across all specialties, and it's one of the most important distinctions in ICD-10-CM. Now, there are times when we code both the diagnosis and the symptom, but only when the symptom is not routinely associated with the condition. Think of it this way: some symptoms are expected. They're part of the disease process. We don't code those separately. Other symptoms are unusual or not typically linked to the diagnosis. Those should be coded in addition. And then we have combination codes, which already include both the diagnosis and the common symptoms. When a combination code exists, we don't add the symptom again. So the key is understanding what's routine and what's not. Falls are a great example of how context matters. If the patient has recently fallen and the provider is evaluating the cause, we use R29.6, repeated falls. This tells us the fall is an active issue. But if the patient simply has a history of falling and is at risk for future falls, we use Z91.81. That's more about risk stratification than current symptoms. And yes, in some cases, both codes can be used together if the documentation supports it. When SIRS is caused by a non-infectious condition, like trauma, pancreatitis, or a malignancy, sequencing becomes very important. We always start with the underlying condition first. Then we follow it with R65.1, which captures SIRS of non-infectious origin. This sequencing applies only when there's no infection documented. If an infection is present, we follow the sepsis guidelines instead. Next, let's talk about severity. If SIRS is present without acute organ dysfunction, we assign R65.10. If SIRS is present with acute organ dysfunction, we assign R65.11, and then we add codes for the specific organ dysfunctions. And here's an important nuance. If the documentation isn't clear about whether the organ dysfunction is linked to SIRS, we must query the provider. We never assume the relationship. Code R40.20, unspecified coma, is used only in very specific situations, mainly when the underlying cause is unknown, or when the patient has a traumatic brain injury but the coma scale wasn't documented. But there are two big exclusions. We never use unspecified coma codes for medically induced comas or sedated patients. Those situations are intentional and controlled, not pathological. The Glasgow Coma Scale is made up of 3 components: eye-opening, verbal response, and motor response. These codes are used primarily with traumatic brain injuries, and they're always sequenced after the diagnosis code. The 7th character is important because it tells us when the score was recorded, and all 3 components must use the same 7th character. One more thing. GCS codes can't be used with non-traumatic coma codes. When multiple GCS scores are documented within the first 24 hours after admission, we only report the score at the time of admission. Pre-hospital scores, like those from EMS, may be documented, but they're not coded unless they represent the admission score. This rule keeps the data consistent and comparable across encounters. Whenever possible, we want to capture the individual GCS components, eye, verbal, and motor, because they give us the most detail. We only use the total score when the record includes the total but doesn't break down the individual components. So think of the total score as a fallback option, not the preferred method. The NIH stroke scale is used to measure neurological impairment in patients with acute stroke. When a stroke diagnosis is present, we assign both the acute stroke code and the NIHSS code. At minimum, we report the initial NIHSS score. This helps capture the patient's baseline neurological status. This slide highlights two important updates. First, R99, death, unspecified. This code is used only when the patient is pronounced dead on arrival. It does not represent a discharge disposition. Second, the old guidance on functional quadriplegia has been deleted. We now rely solely on current documentation and do not use outdated coding logic. And finally, this chapter reminds us that precision matters. A definitive diagnosis always overrides symptoms. We need to pay attention to modifiers like non-infectious in SIRS. We must avoid coding coma in medically induced or sedated cases. And we should always capture severity scales, like GCS and NIHSS, at the correct intervals. Accurate coding in Chapter 18 ensures that clinical uncertainty is documented correctly and that the medical record reflects the true clinical picture. Thank you so much for watching, and I'll see you in the next episode.